Good morning, and thank you for the opportunity to speak with you today. My name is Norman Jigs Quinones, and I'm here to discuss how clinical nurse specialists, or CNSs, can help bridge the gaps in access, quality, and cost effective care, and why the full practice authority is a necessary step. As a little background, the National Institutes of Health, or NIH, examined the current healthcare landscape as well as perceptible future trends. They identified how the interplay of forces of social determinants of health and health equity affect access to care and consequently health outcomes. Nurses working in various intersections of health, education, and communities are at critical and pivotal points within the US healthcare system. They are indispensable catalysts in realizing that goal of attaining best health outcomes. The Future of Nursing 2020 to 2030 report reminds us that achieving health equity depends on strengthening the nursing workforce. On a macro level, the overarching goal for the US healthcare system is to broaden access to care. But the idea of a broad access to care entails key considerations. We need to ensure that the care is competent, efficient, and readily available. We need to ensure that they are affordable for individuals and for the society. And lastly, we need to ensure that there is appropriate choice and accountability. This means allowing patients to be cared for by the most appropriate clinician for their condition and holding every clinician accountable for practicing within their education and specialty. So, what is the current status of our healthcare system? Let's start with the national context. Among developed nations, the US spends the most on healthcare, yet we continue to have the worst healthcare outcomes. We spend $4.3 trillion, or 17.6% of our GDP, on healthcare. This is from the CMS. And yet, we see some of the worst health outcomes, including lower life expectancy, more preventable hospitalizations, and severe chronic disease burden. This mismatch of spending and outcomes demonstrates a system that is not reaching its full potential. It shows a system that is inefficient, essentially. At the state level, California mirrors these challenges. The number of recognized independent providers, that is MDs and DOs, is 147,105. This is based on the California Healthcare Almanac. As far as collaborative providers, that refers to NPs and PAs, there are 47,069 of them. This shows our state's labor capacity to serve its 39.4 million residents. Of note, four of the nine regions in California are still designated as having an undersupply of primary care. One statistic related to this that we can give attention to is the underutilization of CNSs nationwide, who are also providers who can fill in those gaps in healthcare resources. Demand for chronic, complex, and perioperative care is increasing. The healthcare landscape also continues to change with the arrival of new technologies such as AI, more advanced and minimally invasive procedures, such as robotic assisted procedures. This brings a shift in focus from acute care to ambulatory settings, as well as the broad adoption of value-based care and reimbursement models. So the confluence of these represent another challenge within the U.S. within the healthcare delivery system. In this context, in California. To frame this topic at hand, I want to anchor us in the donor-median model. So the Donabedian model posits that structure plus process equals outcome. So to put this into context, structure in this sense would refer to the undersupply of currently recognized independent providers to meet the demand of the population as well as healthcare practice settings. The process in this case would be the restrictive laws that underutilize advanced practitioners from the full extent of their education and training. And the outcome is a suboptimal healthcare results, high healthcare costs, and further increase in spending. In order to meet this challenge, we need to prioritize broadening access to quality care in cost-effective ways by optimizing and maximizing the utilization of all available healthcare providers in the state. Legal scholar Barbara Safriet argues that one of the clearest ways to meet America's healthcare challenge is to optimize all providers, including APRNs, by removing unnecessary barriers. This is not about replacing anyone. It is about using the workforce we already have to the fullest extent of their education and training. This is also not a novel idea. This is rather a sensible and rational action widely supported within the healthcare delivery community. The Institute of Medicine echoes this position as well. In their statement on the future of nursing, leading change, advancing health, they expressed that APRNs must be allowed to practice to the full extent of their education and training. This principle is foundational to improving access, reducing delays, and ensuring timely and evidence-based care. Among the four recognized advanced practice registered nurse roles is the clinical nurse specialists. They are APRNs with graduate level training who diagnose and treat patients, prescribe and manage therapies, lead evidence-based practice, improve systems and processes, educate clinicians, and drive quality improvement. CNSs provide both direct clinical care and systems level leadership. This is a combination of function and skill that no other role fills. This is an important value of the CNS. The evidence of the value of the CNS is strong and consistent. CNS-led transitional care reduces rehospitalizations and length of stay. CNSs improve chronic disease management, prenatal outcomes, and behavioral health care. They reduce hospital-acquired conditions, readmissions, and overall cost of care. And in palliative and complex care, CNS interventions are consistently cost-effective. This shows that the research overwhelmingly supports their value and role as advanced nurse providers. Yet, despite the preponderance of this evidence, California is one of only 7 states that still does not grant CNSs autonomous practice or prescriptive authority. Nationally, 30 states allow full practice for CNS, while 20 states allow independent prescriptive authority. This places California well behind national standards, and this creates avoidable barriers for patients. Looking at the California statute as a barrier, the California Nurse Practice Act describes CNSs as registered nurses with advanced education engaged in expert practice, research, consultation, and clinical leadership. However, it is crucially notable that nowhere in the statute does it affirm full practice authority or independent prescribing. This is a key structural barrier that limits access and slows care. This precludes the state from utilizing the training, skills, and value of CNSs in augmenting access to care within the state and in elevating and advancing healthcare equity, quality, and healthcare practice. So, Safriet identifies several forces that continue to restrict APRNs, and they apply directly to CNSs in California. First is the complex, uncoordinated payment frameworks and policies from private insurers and managed care organizations. Second is the state-based licensure fragmentation that restricts practice beyond what education and certification already validate. As it stands in the state of California, CNSs are still described as registered nurses, and they are limited within the capacity of that scope. And third is the inequitable reimbursement structures that render APRNs ineligible for payment or direct reimbursement for their services. And if they are reimbursed, it is at a sharply discounted rate for the same service that physicians provide. The current barriers to the removal of these restrictive provisions identified are first is the legislative inertia and scope of practice fatigue. This refers to the purposeful inertial retention of the dysfunctions resulting from the historical evolution of state-based licensure scheme. Given the amount of requisite political and suasion capital, it is sometimes easier to let things be, keep the status quo, and do nothing. Additionally, lawmakers don't want to be caught in the crossfire of professional turf battles. They view this as high stakes, low return. It is a fight where they may have little to gain, but a lot to lose in championing reform. This is also called risk aversion behavior. Second is the lack of awareness of CNS's roles among policymakers and the public. This can be attributed to the long-standing predominant dogma in popular culture that doctors know best and that the centrality of the practice of medicine or its functions, any of its functions, are solely and exclusively situated for the physicians. When there is no public awareness of the function of the APRNs and the value that they bring, there is no generation of demand for access and payment, and naturally, there's no payment for their services. And then lastly is, and probably most importantly, is organized medicine's continued opposition to expanding authority and reimbursement of APRNs writ large. Medical organizations actively pursue legislation and activities. They support activities designed to oppose laws that enact authorization of any individuals to practice medicine unless they are physicians. They also oppose laws that would authorize non-physician providers to practice without their supervision. So this causes limitation in for APRNs to practice independently. The good news is that there are efforts underway advocating and pushing for full practice authority for CNSs in California. The California BRN's Clinical Nurse Specialist Advisory Committee is actively drafting regulatory language for CNS modernization. The California Association of CNSs is also engaging with state lawmakers and lobbying for legislative change. Momentum is building, but statutory action and a broad coalition are needed to complete this process. And fortunately, we now have a precedent. The recently passed AB 890 can bolster the standing for CNSs in advocating for full practice authority. AB 890 created a successful pathway for nurse practitioners to practice without standardized procedures through the creation of two new NP categories, the 103 and 104 NP model. This law modernized NP practice while maintaining safety through clear requirements and structured transition to practice, including a pathway towards independent practice. Some of the requirements are having to complete a transition or 4,600 hours of practice. And for the 103 NP, you have to work in a group setting with at least one physician. For 103 for 104 NP, in order to qualify for that, you have to have been an 103 NP for at least 3 full years or 4,600 hours in direct patient care. And you have to be working independently within the population focus of your national certification. Um, the the best thing about this is 104 NPs can practice without standardized procedures outside of a group setting, so they can set up their own independent practice. Um, this similar framework can be adopted for CNS. Looking at states with a similar situation and a similar predicament, we turn to North Carolina. North Carolina's SAVE Act, SAVE meaning safe, accessible, value-directed, excellent care, provides an excellent comparison. This bill was introduced to modernize nursing regulations. It grants APRNs, including CNSs, independent practice. It explicitly defines CNS authority, including prescribing, and the process involved in this had a broad coalition of support from nursing organizations and insurers like Blue Cross Blue Shield of North Carolina, business employer groups like Amazon, and policy think tanks like the North Carolina Center for Nonprofits and Americans for Prosperity. This bill was introduced with the goal of focusing on rural access and increasing workforce capacity. At the federal level, the ICAN Act, ICAN standing for Improvising Care and Access to Nurses Act, was reintroduced in February of this year with the aim to remove long-standing federal barriers to APRN practice under Medicare and Medicaid. If passed, it would modernize federal policies, expand access to rehab, nutrition therapy, durable medical equipment, and hospice certification, and improve access to care in rural and underserved communities. With this, there is now a stronger argument for California to align state laws with this federal modernization effort. Based on these evidence, I offer these key recommendations. Um, First, we need to create a CNS full practice authority pathway modeled after AB 890. Second, we need to update the CNS statutes to reflect modern CNS competencies. Also, we need to align California regulations with federal modernization efforts, such as the ICAN Act, and with the national APRN consensus model. We need to ensure equitable reimbursement and recognition of CNS services. And we need to leverage CNSs in quality improvement, safety, and cost containment initiatives across hospitals and community settings. These steps require no new infrastructure, no new funding, and no expansion of scope beyond what CNSs are already trained for. They simply remove barriers that prevent them from practicing at the level they are already equipped to provide. Lastly, I'd like to close with a quote from Barbara Safriet. Competence does not change with jurisdictional boundaries. The only thing that changes is legal authority. Other states are already maximizing the value of the CNS in order to address the needs and demands of the modern healthcare delivery system. California's CNSs are competent, rigorously trained, nationally certified, and ready to meet the state's growing healthcare demands. What they need now is the legal authority to do so. California is a global leader in healthcare practice and innovation, yet we are woefully lagging on this front, and this needs to be rectified. Thank you for your time and commitment to improving California's healthcare system.